Today we are in CSI conference in 73rd annual conference in Hyderabad. So we have a very eminent cardiologist in the country, Dr. Prathap, and along with Dr. Shiv Kumar, he is from Hyderabad. Myself, Dr. Subroto, and we are just have some small discussion regarding the dapagliflozins, or we can say SGLT2 inhibitors. So to first question
plus
to
RNI.
Plus RNI. So first thing, as I am an interventional cardiologist, is the same definitely with in front of Dr. Prathap. He is a CTO specialist, just we can say. So relatively, we can say that we are making more of heart failure patients after doing interventions. First thing. And second, how to do the intervention for the heart failure, those that developed heart failure with this RNI and this.
No, basically it is, we are not making any heart failure patients. A patient with a heart failure comes to you, and a chronic heart failure patient, we have a lot of time actually these patients will die in front of you in a 1 year or 5 years time. Earlier the mortality was nearly 25 to 37% from the data from the country itself. And this actually in over years what we are seeing actually patients are dying in front of you, but there was no resources to do anything for this patient except the transplant is the final outcome, and CRTD many people cannot afford even for the left bundle is left bundle branch block in the ECG. But I am just telling this medicine actually made a difference to the clinical practice of all the cardiologists. RNI made many patients who are actually having refractory heart failure, repeat admissions in the hospital, cost is very high. Even with the ACE inhibitors, ARB and aldactone and diuretics on the patient, and this RNI made a difference to the patient by the reduction in the usage of all these drugs, especially diuretics. Repeated admission came down drastically and their survival improved. The only situation with the RNI, I feel it is not good, actually not yet proven so far, is the patients with a post-MI situation. Post-MI cardiac failure, we have yet to get a proof regarding this is whether beneficial or not. This is one situation where is, I was actually telling just before to everybody that we have to tell the people that even in a stable chronic heart failure patient, there was a data published from Trivandrum showing that the chronic heart failure patient also, there is a 1 year mortality of nearly 37% happens. And a stable heart failure patient. Actually, we have to, the industry and the cardiologists should change their mind to convert the patients on ACE, ARB, diuretic patients or aldactone patients to RNA early, so that the benefit can be translated and can have a long-term survival. I think Shiva can add on to some of the points.
Yeah. Good morning. I'm Dr. Shiv Kumar from Hyderabad, working with the teams. As I'm presently, fortunately, I'm working as treasurer of CSI, 73rd annual conference. The occasion of this conference, you are learning much, particularly heart failure, and PG track is also very good. And particularly coming to the RNA and SGLT2 inhibitors, becomes a great pillar for the treatment of heart failure. If we see that particular RNA, if we start in chronic heart failure patients, you are able to prevent and mortality and morbidity. And it is not only acting as in place of the ACE inhibitors and ARBs, it has good replacement as a fifth pillar. It has added to the along with SGLT2, beta blockers and MRA. And some extent we know that good mortality benefit was in RNA. Not only that, reductions are recovering the heart failure, and reductions of the indices of LV diastolic dysfunction also is important in that. RNA has decreased antiarrhythmic. Now, once the RNA has come in the market, once we are using for last 3-4 years, it has decreased number of implantation of ICDs. Sudden cardiac death also prevented with the RNA. Now, extra thing, SGLT2 inhibitors, adding that is also initial period itself we are adding SGLT2 inhibitors. And for RNA, we got great data from Paradigm HF trial that it is good mortality on top of the beta blockers. MRA that is one of the great importance with that. No doubt, as Sir has mentioned, Prathap has mentioned that the acute MI with heart failure, Paradise MI trial has not shown that non-inferiority of ramipril with the RNA. That still may require for further studies to show that RNA is good in post-MI heart failure patients.
Okay, one question everybody thinks about that this can be used in a mild renal impairment patient also. Actually, renal impairment is actually one of the problem which makes the people to not to use this drug in a very high. What is your experience in the renal failure patients?
Definitely, initially what we got is that there is those who have the worsening of the renal failure. That means RNA is working very well. And that is the reason once initially and they recover from once you are continuing with that. Initial periods because of decrease in glomerular arterial pressures, venous pressures, there is a worsening of renal parameters. Should not afraid. Those who are not worsening of renal parameters, that means they may not be benefited with RNA. One of the indirect evidence to show that you should not afraid to that.
But you should readjust the medicines. A combination of these drugs are dangerous, and you should be seeing that the medicine to be readjusted, not to deteriorate the renal function.
No, the questions arises. I tell you that the questions is that which is the level that we should consider. Normally, question suppose the patient's creatinine level is 1.5 or so. How long we have to wait?
You have to see in that is potassium level. Suppose potassium is normal and is not worsening more than 30% to the baseline.
Yeah, baseline to 30% we can
told and restart. That's what I was mentioning, that glomerular pressures, arterial pressures will decrease. So worsening of the initially. The major problem with the renal failure is increase the renal arterial pressures.
Yeah. Initially the phase will be increase the creatinine level. After some time that if you continue with the RNA, then it will again reduce the.
One more thing is that even nephrologists are using RNA even on the dialysis patients because we have a lot of limitations what we use in dialysis patients with the severe LV dysfunction.
But actually, one point is actually one major point is actually the RNA should be used in caution in a patient with renal impairment.
Only that is true. Only to look the potassium and serum creatinine.
Okay, I think any other points if you can add on that, Dr. Prathap, some small last.
No, I think one important point is actually patient with the left bundle branch block with an severe LV dysfunction. Always CRTD has a definite role, and those patients benefit out of it. And I always tell that preventive causes to be given the more importance than even drug therapy, because that definitely will make a difference. That is what I was telling. You should not make the LV left bundle branch block with a severe heart failure. You should try to make it a normal sinus rhythm with a narrow KRS complex, which will make your life much better.
So in conclusion, in our discussion, what the three things we could know with the discussion with Dr. Prathap and Dr. Shiv Kumar is that first thing that we have to use more of RNA along with the this SGLT2 inhibitors to give the mortality and morbidity benefits, and definitely I said almost a 37% benefits in the cases of symptomatic and the mortality benefit in 1 year follow up with the in some studies as told. And second thing, the creatinine level you have to guardedly use the RNA in the patients with, if the baseline of more than 30% can be given, if the increases the creatinine level more than 30% of the baseline. And third point I want to add that as already started with, see now the as per our intervention is increasing, and initially whatever the patient's longevity is increasing because of the heart related issues. So the patients will be getting after ultimately after a few years or so after CVGs, bypass surgeries or angioplasties or something. So there may be number of patients will be getting more in future. So the training for the heart failure catering, or we can say that intervention cardiologists or cardiologists should be trained with this heart failure also, that he can cater the more patients and give the more mortality morbidity benefits to the patients. Anything else, sir?
Only in the SGLT2 inhibitors and RNA is most of the times the combination of the heart failure with CKD. Almost 30 to 40% have a CKD with heart failure and diabetic. So DAPA CKD trial also shown the benefit.
Very much. Yeah. Thank you very much.